Senior Satish Bhai.
No.
Sir, because of Satish Pandya and efforts, we are reliving our days where we used to eagerly wait for Saturdays. કે ક્યારે સેટરડે આવે, આજે કોનો ટોક છે.
Yes. So, good morning all. Welcome back to Saturday Club meeting. And we have Dr. Ankur Bhavsar today talking about rational use of and principles of use of antibiotics. Ankur Bhai is an intensivist working at Spandan Hospital. He has experience of 19 years to his credit. So Ankur Bhai, thank you for joining us on this Saturday morning for sharing your knowledge about principles of use of antibiotics. So welcome Ankur Bhai. Ankur Bhai will not be visible today. He has some issues with his camera in the laptop, so we will straightway start with his talk. Ankur Bhai, you can start the talk.
Yeah. Thank you, sir, for generous introduction. I'll share the screen first. Yes. Thank you. Good morning, everyone. I really thank Dr. Satish Pandya, sir, for inviting me to give a talk on antibiotic on such elite club. I'm privileged to do the same. Now, this antibiotic use is one of the very important topic in our day-to-day life. And really, in India, use of antibiotic is quite irrational, which is resulting in development of a lot of multi-drug resistant bacteria, particularly in ICU. And now really we are finding it difficult to treat many patients who is really critical and harboring MDR's pathogens. So let us see how we can, what are the principles we can minimize the resistance and how we can optimize the treatment. So I'll start with some basic how if we think that antibiotic is not started just in last 50 years, it is basically antibiotic used for millennia, and without knowing that substance used is really antibiotic. It was known in last century that infection is caused by bacteria. Around 2000 years ago, Chinese, Serbian, Greek, Egyptian people used to use poultices molded bread to treat the open wounds. And Ebers papyrus was known 15,050 BC, is one of the oldest preserved medical document that included moldy bread. So literature around 3,500 years also had some evidence of use of antibiotic. But the recent antibiotic era has come when Paul Ehrlich developed arsenic-based product Salvarsan in 1909, which has proved effective treatment against syphilis. And it was probably the first truly modern antimicrobial agent. So later work by Gerhard and Dogmack and colleague, they discovered protoncyl sulfonamide product. Now he was a bacteriologist who developed this drug to save his daughter's arm from amputation. So sulfonamide were truly first effective broad spectrum antimicrobial, which is still are in use. Of course, we are using less and less, but still some drugs like Bactrim is really useful in many MDR pathogen as well as simple UTIs. So many of us are not using this, but it is really useful drug. So it all started with the discovery of penicillin. It is not the Fleming who invented penicillin first. There was some evidence in 1870. Sir John Scott Burden Sanderson demonstrated that culture fluid from mold inhibits the growth of bacteria. Years later, Joseph Lister demonstrated that Penicillium gallus has antibacterial effect on human tissue. And 1875, Dr. John Tyndall demonstrated some experiment with Penicillium notatum to Royal Society. And 1907, Ernest Duchenne treated typhoid in Winnipeg by use of mold Penicillium notatum. So it is later Alexander Fleming and penicillin. So he first noticed that culture of Staph aureus growth was inhibited by contaminated blue mold. which was fungus from Penicillium genus, 1928. So that led to hypothesis that microorganism produce some substance that inhibit the growth of other microorganism. So it was named as a penicillin. So right as of now, at this era, a lot of antibiotics are manufactured synthetically, but many of the antibiotics are basically originated from some kind of microorganism only. So penicillin was first of those kind of antibiotic. So it was as drug, it was developed from 1928 to 1940. Actually, after discovery of penicillin, he did not have idea or how to purify and get into the mainstream drug. So in 1940, Howard Florey and Ernst Stein published a paper describing the purification technique. And then came the golden age of antimicrobial. So next 20 years become golden age, we called, because a lot of antibiotics were invented, like streptomycin from some bacterium Streptomyces in 1944, vancomycin from Orientalis in 1958, and then chloramphenicol tetracycline and so on. So then later on, all other classes of antibiotics skip. So why I'm telling all this? Because as soon as some new antibiotics were invented, soon bacteria were becoming resistant to those antibiotics. So important thing is that when we find some or we research new things, most of the time it is misused rather than being used rationally, and that led to a lot of resistance. So as we can see here, in 1959, they developed methicillin, but then it becomes resistant. So 61 ampicillin and later on cephalosporin. In 1995, imipenem was invented. Now this one more important thing called something called beta lactamase inhibitor, that was also invented to counter the effect, because what happens, bacteria also wanted to survive, so they started developing beta lactam antibiotic. What are the beta lactam antibiotics? All cephalosporin, carbapenems, and penicillins are broadly called as beta lactam because they contain beta lactam ring. So bacteria started destroying that beta lactam ring, so we need to invent something which destroys this beta lactamase produced by this bacteria, which is called beta lactamase inhibitor. So clavulanic acid is first of its kind, which was invented way back in 1976. So that was combined with amoxicillin, which make it little broad spectrum, and beta lactam. It is called beta lactamase inhibitor. And later on, two more invented, like tazobactam and sulbactam, which is nowadays used very uh, uh, routinely in all kind of infections. So these are the basically we can see the source these are the actinomyces base. These are, so basically majority bacteria are formed from some kind of natural resources, but recent antibiotics are generated from the synthetic process. So as we see, just wanted to show some resistant pattern. So 1941 penicillin, but soon started resistant. Strep aureus resistant, 1967 strep pneumonia resistance, and so on. So like as soon as antibiotics are invented, 1958 vancomycin, but then we start seeing resistance 1988 2002, amphotericin resistance. Nowadays, the new Candida species is also invented since last around 10 years, which is called Candida auris, which is almost refractory for to the any kind of antifungals. Methicillin was invented in 1960, which later become resistant. Same way, all cephalosporins are becoming resistant. And now the latest antibiotic, what now we are using for some kind of MDR pathogens, is called ceftazidime avibactam, which was invented 2015. But then immediately after a few months, we started, like bacteria started developing resistance to the same antibiotics. So moral of the story is that basically we have to use antibiotics quite rationally, and let us see what are the principles which we can use to reduce the resistance and to optimize the antibiotic treatment. So if we see antibiotic consumption all over the world, this was one article published in Indian Express. So that suggests that almost 46% antibiotic consumption has gone up in last 2 decades all over the world. It's not only India, it's all over the world. Of course, in India, the antibiotic consumption has gone by around 30 to 40% in last 10 years, which is one of the important factor for the development of multi-drug resistance bacteria. So one foremost thing, we have to reduce somehow resistance. So what are the few points which we can consider? So preventing infection itself is one of the factor. which will help us to reduce the resistance. So avoiding infection in first place reduces the amount of antibiotics that have to be used and reduce the likelihood that resistance will develop during the therapy. So there are many ways that drug-resistant infection can be prevented, like immunization, safe food preparation, hand washing. One more most important thing, at least at our setup in our hospitals, is to use bedside hand rub, which after COVID, of course, now people are doing it. But before COVID era, there were hardly the awareness among the nursing staff was not there. So we have to ask for a hand hygiene or hand rub. Just so if we follow this step, then probably we can decrease the transmission of multi-drug resistant bacteria from one patient to one other patients. Another thing, tracking CDC gathers data on antibiotic resistant infection cause infection and whether these are particular reasons, risk factors that cause some people to get resistant infection. So with that information, expert can develop specific strategy to prevent this infection and prevent the resistant bacteria from spreading. And this is the most important thing, antibiotics, improving antibiotic prescribing, or it is called stewardship. So it is the single most important factor. What should we do is that first and foremost thing, stop using unnecessary antibiotic. Like it will come to that point later on. And one, we should start a habit of doing cultures at least in sick patients or in chronic infections, so that we can come to know about our flora. What all hospitals should have their own antibiogram, so that next patient who comes with critical condition, we can target the antibiotic accordingly and we can avoid unnecessary antibiotic. So basically, choose the right antibiotic and to administer them in right way in every case is known as antibiotic stewardship, and developing new drugs and diagnostic tests. So of course, in last 10 years, hardly a few antibiotics has been invented because of multiple reasons. Probably the cost of research of new antimicrobial is really expensive, and there are a lot of regulations from the government side also. So now it is very difficult to have newer antibiotic. But still, if we want to have to fight with this kind of resistance, we need to develop new antibiotics. And of course, newer tests to identify the resistance pattern also, and to find what exactly the genotyping of those kind of bacteria, that also we have to find. Sorry. Okay. So this is just a basic thing I wanted to highlight, how this all become resistance happens. So these are the bacteria which we can see all are susceptible, but there may be, because bacteria also want to survive, they develop some kind of resistance. And when we give antibiotic which is sensitive, it kills almost all the bacteria, but then one resistant bug will strive, and then it will spread this to other bacteria by various methods like plasmid or various. So again, some other bacteria will develop this resistance, and this is how resistance develops. So now comes to the principle of using antibiotic. So I think one foremost thing which I have highlighted before also. Let us see. So I think we should know what am I treating. So many times we have seen some patient comes and stroke patient, or maybe some patient comes with for MI. So many times the antibiotics are prescribed for no reason. So you should know what you are treating. Of course, very critical patient, we need to start antibiotic, but maybe stable patient, or we should know what we are treating. Like if we are treating pneumonia, UTI, and we can direct antibiotic according to that particular system as site of infection. Like meningitis required antibiotic which has good CNS penetration. Lung pneumonia requires the antibiotic which has good lung penetration. One of the important factor is host factors. So like immunocompromised, diabetes, and advanced old age patient may not have classical signs of sepsis or infection. Like those patients may not have classical fever, they may not have tachycardia. So those kind of patients, we have to be very careful. Those patients may have subtle sign of infection like decreased appetite or maybe altered sense serum. So those patients are high risk of developing sepsis, and those kind of patients which may require initiation of antibiotic. Microbiological diagnosis. Try to try to send some specimen before sending antibiotics. It is not possible to send specimen in OPD patients or very stable patient, but patient is very critical, and if we think that there is probably some abscess or some fluid collection is there or there is pneumonia we are dealing, or we are treating UTI which is hospitalized, then try and send culture before starting the antibiotic. This will give a lot of information later on when we want to change the antibiotic or we have to escalate or de-escalate the antibiotic, and it will also help us to know on our flora. So next time patient comes, we can have definite in mind that what organism we are dealing with. Now, whether community acquired or hospital acquired, so this is very important. So community acquired infection most of the time are probably can be managed with narrow spectrum antibiotic. So if patient comes from community acquired pneumonia or community acquired UTI, we don't need to start the broad spectrum antibiotic. So this is one of the reason many of the places it is like carbapenems are started for community acquired pneumonia or maybe some other infection, which is really disturbing, and it causes development of a lot of resistance and development of MDR organism. Another important thing, diagnostic surgical intervention in the recent past. So if patient is admitted, patient is catheterized in the past, or some implant is done, so those patients may be harboring MDR pathogens. So if such patient comes with some other things or maybe some infection, then we have to consider that what are the possibilities that that particular patient is having what organism. So if those patients who are already admitted can be harboring a lot of MDR pathogens. One more important, timing of antimicrobial administration. So if patient comes, this is particularly important in ICU patient, septic shock patient. So some patient comes with severe hypotension, and if we think that patient is having septic shock, then recommendation of giving antimicrobials is within first hour. So if we delay antibiotic, then the mortality really goes up with every hour. So we have to balance to give appropriate antibiotic at appropriate time and not to administer using over antibiotic also. So the other spectrum of patient comes when patients are absolutely stable. We can wait to have some kind of conclusion in our mind that what can be the organisms. Like if some patient comes at around 4 a.m. in the morning and patient is having 102 fever, otherwise patient is stable, so we can come in the morning or we can discuss with the patients, we can obtain the history, and then probably we can start antibiotic according to our thought process and according to history. So sometimes it is not important that if we immediately start antibiotic. We can either we can send some culture and then we can reassess and then we can start, except only 3 conditions where we need to start antibiotic as early as possible, like septic shock, febrile neutropenia, and bacterial meningitis. So one more thing, empiric versus definitive therapy. So important to choose most appropriate antibiotics. So when patient is very critical, inadequate initial therapy may lead to increase in mortality. So initially we have to choose very broad spectrum antibiotic if patient is very unstable. And because we have taken cultures later, once we have cultures in our hand, we can de-escalate according to our culture and sensitivity report. And that is why we need to know our hospital flora. So we should have at least 3 to 6 month antibiogram in our hand before we select that when we select the antibiotic, so that we can suppose some patient comes in my ICU or patient is already there and now developing septic shock. So my ICU probably is having a lot of E. coli and Klebsiella, which is multi-drug resistant. So I would consider to cover that particular pathogen when patient becomes very sick. One more thing, now almost all microbiology lab is doing antibiotic sensitivity test, but we have to interpret it is very carefully. And now it is preferable to have MIC values rather than just +1, +2, +3, or just mentioning sensitive or resistant. So one just we need to compare with our breakpoint. So what exactly the breakpoint is? So breakpoint is a number basically to decide that particular antibiotic is sensitive or resistant. So if our MIC is less than that particular breakpoint, so breakpoint is that it is decided by CLSI that particular antibiotic have given that particular concentration which requires to kill the bacteria. So if our MIC is less than a breakpoint, then it is sensitive more MIC, it is considered resistant. I'll give you example. So it is not like that less MIC. So here if we see here gentamicin MIC for Enterobacteriaceae is 3, amikacin is 6. So we consider the gentamicin is better. But if we consider the breakpoint, so it is given by PLSI and all, so it is there in our lab. So if we can see breakpoint for gentamicin is 2. So our MIC is 3. So it is resistant. So here amikacin breakpoint is 8 and MIC is 6. So it is sensitive. So it is important to compare it with the breakpoint. So if MIC lesser the MIC than breakpoint, more antibiotic is considered to be more effective. So we have to compare our MIC with the breakpoint. Another thing, many times like sensitivity is given. Like I will give example, E. coli comes in the urine, which is E. coli resistant to all except tigecycline. So somebody can think that I will give tigecycline, but then we have to see what is the pharmacodynamic of tigecycline, because tigecycline has very poor penetration. So in that case, we cannot give tigecycline for very bad UTI. So this is how. So we should know what antibiotic we are giving and its pharmacodynamic before we select the antibiotic. Similarly, if my endotracheal secretions is growing MRSA, which is sensitive to daptomycin, but again daptomycin is not. It is penetration in the lung is very poor. So we have to consider antibiotic before we have to know pharmacodynamics of the antibiotic. So sensitivity will pattern to identify ESBL. Now, what is ESBL? ESBL is extended spectrum beta lactamase. So all the beta lactam antibiotic probably is become ineffective by bacteria producing ESBL. So resistant third generation cephalosporin Astiorum may suggest ESBL organism. So in such cases, we have to consider carbapenem, though there is sensitivity shown in the report. Because like piperacillin, tazobactam, sulbactam, we can give, but many times inoculum of bacteria is so high that ultimately during the treatment, it may become ineffective. So when such pattern is there, we have to consider giving carbapenems. So when should we use combination of antibiotics? So it can be considered in critically ill patient before any culture report comes. Beta-lactam and aminoglycoside have a synergistic effect against many gram-negative and gram-positive bacteria. It can be considered for Pseudomonas infection as well. So we have to use combination initially when organisms are not known. Like many times we start with the meropenem, amikacin, or intraabdominal infection, we start piperacillin, tazobactam with amikacin. And sometimes we have to cover entrecocci. So we add either teicoplanin or we add linezolid or whatever organism we think that patient is harboring. Cover anaerobes also.
Okay.
Yeah. So renal modification. So many times failure. So my point is that we don't need to reduce the dose from very first dose. So we have to give loading dose, always give loading dose, and later on we can reduce the dose as per creatinine clearance report. Like all which are in septic shock requires loading dose, like meropenem 2 gram, piperacillin, tazobactam 4.5 gram. So if patient is in renal failure, later on we can give 2.25 6 to 8 hourly. But because underdosing will expose bacteria to suboptimum concentration of antibiotic, which will lead to MDR resistance. So duration of antibiotic microbial therapy, we don't need to give for very long period of time. Complicated UTI is generally 3 days, or maybe if patient is little hospitalized, then maybe up to 5 days. Community acquired pneumonia is 5 days. Even ventilator associated pneumonia 8 days. Long course is only recommended when patient is having which is basically bloodstream infection, and immunocompromised patient, we need to give little longer course. And of course, in osteomyelitis, endocarditis, we may require for a longer period of time. So there are some rules like treat the pneumonia, not the endotracheal aspirate. Here, what I mean to say is that once patient is in the hospital, maybe patient's airway or patient's urethra or catheter are all colonized by ICU flora or hospital flora. So if patients are not having any symptoms, please don't treat those patients. Just if patient is having really, like, I will treat pneumonia, I will treat this CTCS if patient is having fever, oxygen requirement is going up, hypotension. Same way, I will not treat only just on basis of some culture, urine culture report. One more thing I think I would like to stress is that many of patients may be having ASB, which is asymptomatic bacteria, like 40-50%, but they don't have a classical symptoms of UTI like frequency fever or pain in the flank. So ESB needs to be treated only in two conditions. One, patient pregnancy. Pregnancy, if there is UTI, we need to treat, or immunocompromised patient. So these are the only two conditions where if ASB is there, we need to treat it. So when we take culture from like osteomyelitis patient or any ulcer like chronic ulcer, non-healing ulcer, so we have to take from deeper tissues culture and not the skin flora, because those are colonized by our ICU flora. So these are some factors we have to consider when we choose the antibiotic. We have discussed almost all factors except this pharmacodynamic properties. So for optimization of therapy, to minimize the side effect and to minimize the resistance, we have to consider pharmacodynamic and pharmacokinetic properties of the drugs, as I have discussed in some previous slide. So what is pharmacodynamic? Pharmacodynamic is that what is the effect of drug on that particular patient? Like what are the side effects? What is the penetration in different tissues? So this is called pharmacodynamics. And what is the pharmacokinetic? What happens to that drug? What is the concentration of that particular drug over a period of time? So that is a pharmacokinetic. So let us see what are the example of this thing. So there are two kinds of antibiotic described. One is concentration dependent activity. So here we have to achieve maximum concentration. So that drug will be very effective if we have peak concentration. So here, if I see area under curve, 24 area under curve to MIC, if it is more than 25 to 30 in immunocompetent and more than 100 in immunocompromised patient, so it will have maximum effect with minimum adverse effect. And if we see the peak drug concentration to MIC, it should be more than 10 for such kind of drug. We'll see which are these drugs in which we have to achieve. So here what we have to do is we have to give single dose rather than multiple time dose. So single dose with maximum concentration we have to consider. So other is time dependent. So here what happens that it refers to time take for a pathogen to be killed by exposure to antimicrobial. So here we want to achieve maximum concentration MIC, concentration of drug more than MIC for long period of time. So around generally 40 to 50% of dosing interval, if that particular drug's concentration remains above MIC, then it is going to be very effective. So if I talk aminoglycoside, it is concentration dependent activity. So here I would like to give 1 gram OD rather than 500 BD, so that it will have minimum renal toxicity, as well as it will have good amount of killing of the susceptible bacteria. Same with quinolones. And all the beta-lactam antibiotic, penicillin, cephalosporin, carbapenems are considered time dependent. So here we would like to keep MIC drug concentration above the MIC at least 40 to 50% of period of time between the dosing interval. So here many times if we are finding drug resistant bacteria, then we give infusion. Like I give meropenem in infusion over 3 hours, doripenem or 4 hours, imipenem or 2 hours after loading dose. So here then possibility of killing the bacteria is more if we give in infusion. And there are some antibiotics which have both the properties like vancomycin, linezolid, and daptomycin. So judicious use of antibiotic, newer medicine, new methods of cure always works miracle for a while only. Like, so bacteria are very smart to develop resistance. So there are some potential error when we prescribe the antibiotic, like use in absence of infection. So like viral infection, like in COVID, when patient comes, we don't need to administer any kind of antibiotic. Same way for diarrhea and probably upper respiratory tract infection, we don't need to give any antibiotic. While patient is admitted indoor, a stroke patient may not require any kind of antibiotic. and I have failure to use in presence of infection. So as I have told, many infections in old age or immunocompromised patient may not have classical sign. So we have to consider those patients like subtle sign of hypotension, altered sensorium, patient not eating well, and so these are certain signs of infection. So we have to consider this when to start antibiotic. Prolonged use, as I have mentioned, it is generally 7 days is recommended in majority of the time. Higher antibiotic for community-acquired infection, like we should not use carbapenems for community-acquired pneumonia. So probably ceftriaxone is as good as meropenem for community-acquired infection. So even if patient is having hypotension, both antibiotics are okay. Inadequate source control. So we have to see if there are pus pockets. So like liver abscess requires drainage once it is liquefied. If there is subhepatic abscess, we need to drain it. So ineffective initial choice, delayed administration first dose of antibiotic, appropriate dosing, as I mentioned, we have to give loading dose followed by full dose. Failure to culture and failure to de-escalate. These are some errors which we can always think before we prescribe the antibiotic. Now, use of antibiotic in fever. So all fever in ICU are not because of bacterial infection. So all fever do not require antibiotics. So like I'll see what are the causes of non-infectious causes of fever. So prescribing antibiotic without source control leads to more resistance by exposing bacteria to suboptimal doses of antibiotic. So these are some common causes of non-infectious causes of fever, which like acalculous cholecystitis, drug fear. First week of pancreatitis really do not require any antibiotic. Burns first week do not require any antibiotic. IC bleed can have sometimes fever, but IC bleed, stroke, MI, all this patient can have fever, but those situations do not require antibiotic. So if we really use this judiciously, then we can definitely have less resistance pattern. So these are some reasons when we have to consider using antibiotic, like when patient is immunocompromised, like hypothermia, leukocytosis, unexplained tachycardia, unexplained oliguria, altered sensorium, edema, old age. In such patient, we have to consider clinically if we might be dealing with the infection. So these are some just last few slides. This is I have taken from our own Indian guideline, which is national guideline described. Even guidelines are given by ICMR. So majority outdoor patients, if we are dealing with community-acquired pneumonia, co-amoxicillin or macrolide is okay. Beta-lactam is preferred over macrolide due to high prevalence of macrolide resistance. Outpatient comorbidity with use of antibiotic last 3 months, those we may be dealing with some kind of MDR, so amoxicillin or alternative or cefuroxime. In patient non-ICU, in hospital patient, we may require ceftriaxone or and with macrolide. Patient in ICU probably it's okay to have same antibiotic or maybe present azobactam after taking cultures. If patient is having risk factor of pseudomonas, who are the patient who is having risk factor? So any patient who is hospitalized and received antibiotic in last 3 months are high patient who have high risk factor for pseudomonas. Similarly, community-acquired intra-abdominal infection, we can have use either severe sulbactam, present azobactam. If patient we consider that is hospital-acquired, then probably carbapenem or maybe cholesterol tigecycline. Or if we are suspecting enterococci, then we have to consider using tigecycline also. It will cover, or maybe teicoplanin. And if patient have prolonged hospitalization, perforation, then we have to consider using antifungals as well. So infected pancreatic necrosis, imipenem with vancomycin, and we have to, if possible, take necrosis fluid for the culture. Cholangitis as same as for intra-abdominal infection, liver abscess, probably several sulbactam or azobactam. Skin and so now here I want to stress that all skin and soft tissue infections are not because of Staph aureus, and if Staph aureus is there, all are not MRSA. So majority time cellulitis we can get away with amoxicillin or cefazolin, and 5 to 7 days is required. Necrotizing fasciitis, we need to give clindamycin to cover anaerobes. Similarly, abscess, clindamycin, ampicillin, sulbactam, or if we are suspecting MRSA, then only we have to use linezolid. Bacterial meningitis, if elderly population, ceftriaxone and vancomycin is recommended. Meropenem is not recommended for community-acquired meningitis. And if age is more than 50, we have to consider ampicillin to cover the Listeria monocytogenes. Again, urosepsis, acute cystitis, mostly nitrofurantoin is okay, but if patient is very like pyelonephritis, then we should not use nitrofurantoin. This really co-trimoxazole is really effective for majority of stable UTIs. But for pyelonephritis, we have to use piperacillin, tazobactam, ertapenem, imipenem, or meropenem according to culture report. Later on, we can modify according to culture reports. These are some prostatitis, epididyma, orchitis, antibiotic guideline. This is surgical prophylaxis. So here, surgical prophylaxis is recommended only 60 minutes. One antibiotic shot we have to give before 60 minutes, and other antibiotic shot if surgery is prolonged for 8 to 10 hours, then only we need to give second dose. So majority places antibiotics are given for at least 5 to 6 days, which really is one of the factor for the development of resistance. Majority of the orthopedic surgeries, cefuroxime 1.5 is okay. And these are the majority times cefazolin, sulbactam single dose is recommended for the prophylaxis. So I would request not to use prolonged antibiotic or just clean surgeries. So I have taken this from National Treatment Guideline, which is our own guideline, and ICMR guideline. Just a few, sir, do we have some 2-3 minutes? Yeah. So.
No, we have enough time. We have enough time. You can talk for 10 minutes more, no problem.
Yeah. So these are some now what problem occurring in all the hospital or in all the ICU, including my ICU, is the development of multi-drug or we can pan-drug resistance bacteria. So how to manage? We have some guidelines given. So definition, how do I define MDR or multi-drug resistance? So multi-drug resistant bacteria is acquired non-susceptibility to at least one agent in 3 or more antimicrobial categories. So I'll give example now. Like this is my own hospital. Urine culture is showing E. coli, which is resistant to this amoxiclav, like it is so penicillin resistant, third generation cephalosporin resistant, and resistant to fluoroquinolones. So this we can call this MDR. Second category comes the XDR, so non-susceptibility to the at least one agent in all but 2 or fewer antimicrobial categories. That means it is susceptible to generally 1 or 2 class only. So this is some patient growing Klebsiella pneumonia in blood. It is, you can see, resistant to everything except this cholesterol. So this is called Klebsiella, and this is the reality. Now in India, almost all the ICU, around 30 to 40% of patients harboring Klebsiella pneumonia, which is resistant to almost everything. And this category, PDR, pan-drug resistance, which is not very common, but some of the hospitals or ICU are growing organism which is resistant to everything. So here it is very tricky what antibiotic to start. So these are, I would call, these are the monsters basically of the ICUs, which is called CRE, which is carbapenem resistant enterobacteriaceae, which contains E. coli and Klebsiella, Pseudomonas, Acinetobacter, and MRSA. Now MRSA is not very common in India, though we do found, but the percentage would be less than 10% in majority of the ICU. Majority of the time, what bacteria we found in our ICU and our hospital floor is these 4 bacteria. This comprises around 70 to 80% of the flora. So what are the risk factor of developing MDRO? So exposure to MDRO, history of MDRO. So some patient is having history of multi-drug resistant organisms. So those patients are one of the risk factor. Those are the patient in which we can consider giving antibiotic targeting this organism. Colonization pressure. So single antibiotic exposure in the hospital can lead to development of MDRO. Recent antibiotic exposure. So it is said that last 3 months, any antibiotic exposure patient is at high risk of developing MRSA and Pseudomonas. recent hospitalization, comorbidity, and if patient is having any of this, like any chronic wound, patient is having chronic catheterization, indwelling devices, or structural lung disease like COPD, those patients can be harboring a lot of MDR organism. So these are some guidelines. Guideline is taken from IDSA, how to deal with ESBL, which is extended spectrum beta lactamase inhibitor. So if we are dealing with cystitis, maybe probably nitrofuranate trimethoprim is okay, amoxiclav is also okay. But if we are dealing with a pyelonephritis, then probably we have to give ertapenem, meropenem, imipenem, and this fluoroquinolones as per sensitivity report. And if infection is outside the urinary tract, then we have to consider giving carbapenems. This is for ESBL. ESBL majority time, as I have already told, we have to consider giving carbapenems only. And this is the last one or two slide. This is guidance on diagnosis and management of carbapenem resistant gram-negative. I would call it CRA, which is carbapenem resistant enterobacteriaceae. So what has happened in last few years that because of overuse of meropenem and imipenem, all the ICUs are now harboring carbapenem resistant enterobacteriaceae. So for what we can do for that? So for that, we need to have genotyping of the specimen. So genotyping is done in various the lab. So they will give us what are the carbapenems they are harboring. So there are three kinds of carbapenem what commonly seen in our India. One is, as you all know, name was given NDM, which is New Delhi metallo beta lactamase. Another is OXA 48, and third is KPCs. So the most common in India is NDM only. So now we have to consider giving prolonged infusion of newer antibiotic, which is ceftazidime avibactam, which covers KPC and all ESBL and aztreonam. Aztreonam will cover this NDM. So this is as of now, though the evidence for this is very low, but this is given in most of the guideline, even in IDSA guideline, this is they have promoted this molecule. So other choice is polymyxin. We have to combine this with some tigecycline aminoglycoside as of culture report. But we should not use carbapenem, means meropenem, if MIC is less than 16. So tigecycline also can be used, but it is not good for bloodstream infection or for the pneumonias. If you are using for bloodstream infection pneumonia, we have to go with the higher dose. I'll mention the doses which is required. So if we are dealing with metallo beta lactamase and OXA 48, we can give same ceftazidime avibactam plus aztreonam, or these are the choices. If we are dealing with OXA 48, only ceftazidime avibactam is okay, and these are the other options. And KPC is with which is KPC is basically Klebsiella pneumoniae carbapenems, which is not commonly found in India. So, but if we found, in some cases if found, we can just use ceftazidime avibactam, drug of choice, and these are some other options. So we can have carbapenem resistant Acinetobacter. So for that, we can use very high dose of sulbactam or ampicillin sulbactam in high dose. We can use polymyxin, minocycline, tigecycline. Now whether to use this drug as a combination or not, it is very debatable. But if patient is stable, we can get away with the single agent. If patient is very unstable, we have to combine one of these two agents. Nebulized antibiotic as of now is not recommended in Acinetobacter. And carbon-resistant Pseudomonas, we have to consider giving ceftazidime avibactam or aminoglycoside or polymyxin. As I have told, severe infection, we require combination. If patient is stable, single agent is okay. So if as this all we have discussed, so when we are using tigecycline outside the urinary tract infection, we have to use higher dose. And these are the dose: ceftazidime avibactam 2.5 gram 8 hourly with aztreonam 2 gram 8 hourly, colistin 9 million loading followed by 4.5 12 hourly, polymyxin 15 lakh bolus followed by 7.5 12 hourly, meropenem 2 gram 8 hourly as high dose, imipenem 1 gram 8 hourly, tigecycline 200 loading followed by 100 BD, minocycline 200 BD. So I think this is all regarding the antibiotic. It was little lengthy, but the take-home message is that judicious use, not to use in viral infection, not to use in all the fever. Take culture before we start any antibiotic, at least in critical ill patient, and de-escalation once we have culture report. This is the last slide. Thank you very much, sir.
Thank you, Dr. Ankur. It was not actually lengthy. It was very comprehensive, I would say, because rational use of antimicrobials is a very big topic, and you covered so well in 45 minutes or so. So thank you very much. You can stop the screen sharing. We can have more discussion.
Yeah, sure.
In pediatrics, our organization, the IAP, Indian Academy of Pediatrics, way back in 2014, had brought out a module called Rational Antimicrobial Practices. A very well done module, and it has caused a lot of awareness amongst the pediatricians about rational use of antimicrobials.
Sir, it is more common in pediatric, but in at least adult, really antibiotics are used irrationally.
I know. Can you please stop the screen sharing so others can see? So that module actually made a lot of difference. No, so any efforts which are bringing in awareness about rational use of antimicrobials, they go a long way. We have also made a module for family physicians. All those who are in this audience, family physicians, can log into IAP website and look for this rational antimicrobial practices, RAP module for family physicians. So it talks something very basic about rational use of antibiotics. So your talk was good, very good, Dr. Ankur. And now the house is open for any discussion, questions, comments.
In the present era, I think this is a very useful and very informative talk. We have to use this because there are a lot of rampant and misuse of antibiotics already going in everywhere, I think.
Thank you, sir.
To acknowledge efforts of Dr. Kiran Bhai, I must say that thank you, Kiran Bhai, for helping find us this speaker.
No need to do that, sir. Okay.
Thank you, sir.
It's all our job. Everyone has to participate and do.
Thank you.
Yes, sir. My comments are during COVID era, really antibiotics were misused, and we have seen patients getting meropenem from very first day. And we have seen, because we are receiving a lot of COVID patients, many patients were just no oxygen requirement, still they were getting meropenem teicoplanin. So this is, and so such patient comes to our ICU after 10 days, then secondary infection, then we don't know how to deal with such kind of patient. And that was one of the factor for very high mortality when patient was like very critical. So same things are, at least in adult population, antibiotics are really misused. So I think we need to control that.
And with no new antimicrobial coming in the near future, I think we are staring at a very bleak future as far as antimicrobial resistance is concerned. People say that we'll be back to pre-antibiotic era because there won't be any antimicrobials to fight the microorganisms. So that awareness has to be. Ankur Bhai, I mean, you were talking about stewardship. So what is the scenario in Baroda in general and your hospital in particular? How exactly you manage? Because every individual physician has his own way of treating patients. So is it possible for you to control other physicians in your setup?
Sir, basically, fortunately, our ICU and our hospital have very controlled atmosphere, and the majority of times we have definite protocols. When we start some antibiotic, if possible, we send the cultures. We don't start. So it's basically our hospital policy. So we have a hospital policy, and our hospital is basically a kind of closed hospitals. We have not too many physicians who are coming. So all are we are well tuned with each other, and so probably it is possible to control the antibiotic in our hospital. Of course not, I cannot control everything, but probably 70-80% of time antibiotics are used quite rationally in our hospital. In corporates, hospitals are closed, probably it is possible to have antibiotic stewardship program, but it is really difficult when hospital is open to all, because it is really difficult to control or to tell a physician that please don't use this antibiotics. So it becomes little bigger issues.
Right. Any other comments? Dr. Sabnam Mansuri is asking about importance of blood culture. Should it become more common? Probably what she wants to ask is that
I
should
think,
it
sir,
become very common?
what I have seen in our hospital, at least, if patient is coming with 2 to 3 days of fever persistent, and many of those patients are harboring salmonella, and really I'm telling that 50% of such patients we are getting salmonella typhi positive. So it really helps. It is helpful rather than just of course OPD basis we don't need to do culture, but if patient requires admission, persistent fever after 4 to 5 days, so I think blood culture should be collected so that at least such kind of infection salmonella can be picked up and then we can treat. We don't need to go for higher antibiotics. Still ceftriaxone works as good as meropenem. So I think blood culture, at least in hospitalized patient with 4 to 5 days of fever, I would consider taking blood culture.
Right.
Particularly in blood culture, the technique is also important and timing is also important. That is also very good. You have to keep in mind. Otherwise, irrational use of this blood culture and sensitivity is also has no more.
So
Because if you
blood
don't do
culture
it in
also,
timely, if don't you do timely, or take only
yes,
one set will not be suffice. That is also equally important.
yes, so blood culture always should be 2 sets of culture minimum and 3 sets if required. One aerobic and one anaerobics. And that too, we need to clean that area with very with good precaution. Otherwise, we'll get all the skin for only in blood culture. So then we may treat colonization. So it is also very important to clean it. To train our staff to take blood culture also is very important, and it is required at least 2 sets. Not one set is never okay.
Dr. Jagdish Bhai, you wanted to make some comments? I think he has left. Yeah.
Irrational behavior is in human nature, and this rational talk on antibiotic we have been doing for last almost 40-50 years, but behavior of doctors remains almost same in spite of these talks.
Sir, unfortunately, we do not have any outcome measures, methodology to evaluate whether our campaigns are working or not. But the general feeling is that this kind of talks, this kind of seminars, modules, workshops, they do help. I mean, they go a long way. If you look at our practice, pediatric practice at least, it does help. And way back in late 80s at KGP Children Hospital also, Dr. Arun Phatak sir had evaluated this use of antimicrobials in diarrhea. And since that study, it was observed that the antibiotic usage in diarrhea had reduced. So this kind of efforts do go a long way. It's a difficult, to change the precision behavior of doctors is a mammoth task, but it does help. I wouldn't say that these efforts go waste. In fact, I was going to ask you, Jagdish Bhai, that you are managing KGPCH for a very long time. So do you have any antimicrobial stewardship in KGP Children Hospital? Because there are many consultants who visit KGP Children Hospital.
Yes, but we do not have a definite policy. I have been involving infectious disease specialists to oversee the antibiotic use, and she does guide.
Satish Bhai,
Yes.
most of the modern corporate hospitals or even in university hospitals, they have a clinical pharmacologist who monitors each and every prescription. At least in the past institution I was, from day one, we had a pharmacologist to monitor whatever antibiotic was prescribed, especially in vulnerable oncology patients. So that is one. The second point is the main cause of not implementing it is we say something and the actual ground situation is different, because our own colleagues criticize the doctor that he should have gone in for meropenem or he should have gone in for a higher antibiotic. And the most important is PKPD is not known and it is not accepted. It is not logically told to the relatives or dawa apo, haju bhare dawa apo, something like that. And so doctor is in a fix. More medicine he gives, more antibiotic resistance is happening, more social blame comes to him that they are using allopathy, is using higher antibiotics and things like that. So this is a vicious cycle in which only unity of the Indian Medical Association can help, that this is the prophylaxis or this is the antibiotic policy, and we all follow it, and whatever the other doctor has done or whatever is followed is to be done. Like antibiotic does not penetrate fat, pancreatic or destroyed or necrotic tissue. The answer for me is in the science. Only a single line sentence is antibiotics can be used where blood goes. Even that is not understood by even doctors.
Right. Thank you for pointing that out. And as we all agree, this is a mammoth task and it requires multi-pronged approach. So yours is one of those approaches which help. In fact, when you talk about clinical pharmacologists, what comes to my mind is a good collaboration with a microbiologist.
Yes.
That goes a long way. There are hospitals like say Hinduja, where I have heard that is the microbiologist who will actually command the users of antibiotics in that hospital. It is
Sir,
so strong.
is-
It is such a strong department there that there is such a good collaboration between clinicians and microbiologists that they work in tandem and to minimize the antimicrobial resistance. Yes, Dr. Bhavsar, you were saying something.
Yeah, my critical training is from Hinduja itself. So I know.
So you can share.
Yeah. So Camilla Rodriguez, Dr.
Yes.
Camilla Rodriguez is a microbiologist, and physician, or they cannot use empirical meropenem. If they use them, they have to answer to a microbiologist. And always, many times, our sir, Dr. Farhad Kapadia, generally before goes to ICU, goes to microbiology department and this is what is happening, what is the sensitivity report. But yes, it's very strict not to use irrational antibiotics in Hinduja. And it is again a closed hospital, so no one from outside can come and start their own treatment. So that is one of the factor why it is very rationally used in Hinduja.
So we on our own can also establish good relationship with our microbiologists, be in contact with them, be in dialogue with them, and then evolve our antimicrobial policies. That can also help.
Yes, sir.
So thank you all for very good interactive discussion. Thank you, Dr. Bhavsar, once again, and Dr. Kiran for arranging this session. So we look forward to another such talk in future on antimicrobial rational use. So thank you all. We close the meeting here. We meet next Saturday again, where we'll have Dr. Jaiprakash Purohit talking to about retinal disease. So
Thank you.